So this is chapter 15, respiratory emergencies. Difficulty breathing is a very common complaint. This is also called dyspnea. Remember again that shortness of breath or difficulty breathing is more of a symptom than a sign because you can't definitively measure how short of breath somebody is. It certainly can be caused by several different conditions. Some of the more common is the common cold, asthma, heart failure, pulmonary embolism. And because so many different things cause shortness of breath, it can be really hard to determine what's actually causing it. You may have several different problems that are contributing to the patient's shortness of breath, and so trying to pick out one is going to be pretty rough. However, like we talked in the last chapter, you don't always have to have a definitive diagnosis, especially in the field. If you can figure out what is not going on, oftentimes the possibilities that are going on will be treated pretty similarly. And if you focus on those life threats, those ABC conditions, they're all going to have similar treatments. So we've got the respiratory system that's really divided into two different parts. You've got the upper airway and you've got the lower airway. And then you have all of these structures that contribute to actually breathing. So the diaphragm, your chest wall muscles, other accessory muscles of breathing, and then the nerves that control those muscles. The upper airway, we've already talked about the anatomy of it, so we'll just do a quick overview. It's basically everything from the mouth and nose down to the larynx where your vocal cords are. The lower airway is the the larynx all the way down to the alveoli within the lungs. The principal function of the lungs is ventilation, leading to respiration or the exchange of that oxygen and carbon dioxide at the alveolar level. You can see the picture representation here. So you've got two different parts of ventilation. You've got respiration or inspiration, which is breathing in or inhaling, and then you've got expiration, which is the act of breathing out or exhaling. It does say respiration here, but the inspiration, exhalation, that is a mechanical process, so that is ventilation. Respiration is the exchange of gases that are at that alveolar level, that capillary level. So in the alveoli, your oxygen is going to pass into your capillaries because that blood right there has a low partial pressure of oxygen. So in order to try and balance it, oxygen is going to pass into the capillaries. Carbon dioxide is very high in the blood at that point, very low in the lungs, and so it's going to switch to try and equal out that balance. The brainstem is used to sense the level of carbon dioxide in arterial blood. If the level of carbon dioxide drops too low, the person starts breathing at a slower rate, not quite as deep, in order to try and bring up the level of carbon dioxide within the blood. If the level of carbon dioxide rises too high, then the person breathes more rapidly and more deeply in order to try and blow off some of that CO2. Pathophysiology. There's several different ways that exchange of oxygen and carbon dioxide can be hindered. This can be conditions in the anatomy where it's just abnormal or there's some sort of pathologic problem going on with the actual anatomy. It could be a disease process, could be a traumatic condition, or there could be an abnormality within the pulmonary vessels that's going to interfere with that blood flow. It's definitely important for us to recognize the signs and symptoms of inadequate breathing and to know what to do about it, to figure out how to help our patients. Because it's an A, B, or C condition, this is a life threat. This is definitely something that an EMT should understand. There is a condition called hypoxic drive. It causes CO2 retention. Some patients already have an elevated level of carbon dioxide in their arterial blood. Typically, this can be because they have problems with exhalation because of lung disease, or their body just naturally produces too much carbon dioxide. So if those levels stay high for a great length of time, the respiratory center in the brain doesn't know how to function the way that it would in everybody else because that CO2 is predominantly high all the time. So what happens is your brain is going to accommodate for that high level of carbon dioxide and instead start using a backup system to control breathing. And it's going to start watching levels of oxygen first rather than CO2. So we do want to use a little bit of caution when administering oxygen to these patients. We don't want to overload them if we don't have to, because it could reduce their drive to breathe. However, we do not withhold oxygen from anybody that's complaining of shortness of breath. You just are a little more judicious in how you administer oxygen to them. So dyspnea, again, trouble breathing, can be caused by several different problems. And if the brain is truly deprived of oxygen, the patient may have an altered mental status, and they may not actually be able to tell you what their complaint is. So medical conditions that we end up running through to kind of check off that list of differentials would be pulmonary edema or fluid within the lungs, hay fever, just kind of a common allergic reaction, nothing that's going to truly be a problem a lot of the time. Pleural effusion, obstruction of the airway, hyperventilation syndrome. That's where we used to have people breathe into paper bags. We don't do that anymore. Could be environmental or industrial exposure, carbon monoxide poisoning, and then drug overdoses as well. Just be aware that they may have several different problems underlying that's actually causing their shortness of breath. So it could be that there's a problem with the gas exchange between the alveoli and pulmonary circulation. Excuse me, I'm sorry. This could be because of fluid in the lung, could be because there's an infection, could be because the alveoli have collapsed on themselves. This is called atelectasis. If you don't take enough deep breaths that actually keep those alveoli open, they'll just kind of start collapsing on themselves. It can be that the alveoli are damaged and can't transport gases properly across their own walls. It could be that the passages are obstructed. This can be by muscle spasm, mucus, or if they have a weak, floppy airway wall. Blood flow itself could be obstructed to the lung by blood clots, which obviously is going to hinder the ability to exchange. Or the pleural space could be filled with air, excess fluid, so your lungs can't properly expand. And here's just some causes or some signs and symptoms of inadequate breathing as well. Besides just being dyspneic or short of breath, they may also complain of their chest being tight, not necessarily pain, just it feels tight, or that they just can't get enough air, which is called air hunger. They just are craving air because they just feel like they can't get enough. Dyspnea is a very common complaint with cardiopulmonary diseases. So it may not necessarily be the lungs, it may be the heart, but they're so intricately entwined that sometimes one causes the other. Congestive heart failure causes the heart to pump inefficiently and then deprives the body of oxygen. Pulmonary edema is associated with congestive heart failure. Pulmonary edema is just fluid in the lungs. Severe pain even can hinder the patient's ability to breathe. It could cause them to have rapid, shallow breathing, even if there's not a pulmonary complaint underneath of that or something with the pulmonary system that's causing the exchange not to happen. It could just be that they're not able to take an adequate breath. Upper and lower airway infections. Um, these basically can affect all parts of the airway. It just depends on the person and how they react to it or how their body reacts to it. But some sort of obstruction is going to cause dyspnea. It may range from mild discomfort to someone that requires aggressive respiratory support. And you tend to not get adequate oxygen delivery to the tissues a lot of times because you can't get in enough air. The problem causing dyspnea is always some form of obstruction when you have an infection in the airway. It's either mucus and secretions that obstruct airflow. This can come from that common cold or can come from diphtheria. You can have swelling of the soft tissues in the upper airways, such as seen in epiglottitis and croup. Or you can have impaired exchange of gases at the alveolar level, which is common in pneumonia. Make sure that you have appropriate PPE when you're contacting patients that could have an upper or lower airway infection. Specific conditions. So croup. And croup actually isn't a separate disease in and of itself. It's some sort of virus, just common cold that affects kids typically between 6 months and 3 years of age, can go up further depending on the child themselves. But this illness, this virus, where it may not cause croup in one kid, another kid will get inflammation of the pharynx, larynx, and trachea, which makes it hard for air to pass in and out. The hallmark sign of croup is stridor, so that noisy, whistly sound, and then a seal bark cough, because kids have to cough a lot harder to get air out because of the swelling. Typically, croup clears up on its own. You don't have to do a whole lot for those kids. Most of the time, it's going to be a virus, so antibiotics are ineffective. What can be helpful is humidified oxygen. If you don't have that, having mom or dad take them into a bathroom, closing the door, and turning on the water all the way to hot and making it very steamy in the bathroom is typically going to be enough. Some kids respond really well to cold. So if it's cold outside, you can take them outside, and that tends to help them out. If they're at the point where they're having severe distress, then there are some medications that they can have at the ED, putting them on some steroids to try and reduce that inflammation. But truly, croup in and of itself oftentimes is not an emergency, and it passes super easy from kid to kid, especially in daycare centers, where all those little kids are basically just little petri dishes running around. And so this virus can cause croup in one child and nothing in another child, but they end up sharing it like crazy. Epiglottitis, this is a bacterial infection that causes inflammation of the epiglottis, which can be extremely scary. Kids are often found in the tripod position and drooling. We try very hard not to upset these children. This develops super suddenly. They look sick. They report a very sore throat, high fever. Treat them as gently as possible. Very little movement, because what can happen is that big swollen epiglottis. In kids, it's already super big compared to their airway. And if it gets too inflamed, it can slam shut and they're not getting any more air in, period. So we really just want to keep them comfortable, provide oxygen. We're not putting anything in the mouth. We're not worried about getting them too agitated, because that can really make things worse for them. And we'll stop here.